California's new right to die law, nursing leadership roles and implementations to potential candidates. Presented by Luis Esqueda, Ryan Hood, Zara Mora, Rachel Satani, Maria Catherine Blanca Carmona. Nursing 450 Group Project. It's the right to die. Thank you.
Hi, everybody. My name is Zara Mora, and I'll be presenting introduction, position statement, and theoretical basis for a position. California Right to Die Act passed in 2015. This law allows terminally ill patients to obtain lethal medication to end their lives when and where they choose. Domboski A. Nurses, this role is evolving nurses to identify potential candidates who may benefit from this. And it's making patients aware of this new law and how autonomy and dignity is kept throughout the process. Before this law, people had to wait to die and they had no say about their deaths. This law has opened new doors where people can choose when to go and do this on their own terms. Position statement is our thesis statement is that nurses should take leadership roles to implement compliance with California's new right to die law for patients who are eligible for and request this service. The new law should be presented more often, emphasizing the patient's dignity and autonomy so that the most amount of people can benefit from this new law. It's revolutionary because nurses are really known for prolonging life, and now they're kind of promoting death. They're sharing this new law with patients that may want to end their lives on their own terms and the way they want to do it. This gives them autonomy and dignity. The theoretical basis for our position is grounded theory. It's the theory that is constructed inductively from a base of observations of the world as it is lived by a selected group of people, Haber J. and Lobe Underwood G. It's used in qualitative research. Identifying the phenomenon is the use of nurses identifying candidates and initiating the California Right to Die Act for patients who may be interested. Data is collected through interviews, skilled observations, and open-ended questions. Thank you very much. Bye.
Hi, my name is Rachel. I'm going to be sharing the interview portion of our project. So I actually interviewed Dr. Sunita Puri. Dr. Puri is the clinical assistant professor of medicine for palliative medicine and the supportive care team for the Keck Hospital of USC, USC NURS Comprehensive Cancer Center, and LAC USC Medical Center. She's an expert on this topic because of her years of involvement with palliative medicine. With the recent passage of the new law, our hospitals needed policy written to incorporate the law into practice in our institution. Dr. Puri has been consulted to write that policy, and she has given many lectures and in-services to medical and hospital staff about the details of the new law. So I asked Dr. Puri, how is this law similar to or different than other states' laws that they have? And she said that the law in California is very similar to many other states, particularly Oregon. I asked, how do we deal with healthcare professionals who morally object to participating? She said, under the law, no healthcare professional is obligated to participate in any way. In our policy at the hospital which I work, Norris and Keck Hospital, she has specifically written that under the law, physicians have a right to choose not to participate in this act on the grounds of moral objection, and they are completely protected in exercising that right. I asked, what is the cost of obtaining the medication, and is it covered by insurance? Dr. Puri responded that the estimated cost is around $3,000, which includes both the medication, which is likely secobarbital, and additional medications to assist in the alleviation of any side effects, such as nausea and vomiting. Different insurance plans have different policies on the coverage. None of them, however, are allowed to advertise that they cover this medication. I asked if this is a medication that could be administered in the hospital setting, or is it done solely at home? And she said that it is intended for outpatient use. And in the hospital which we work, Keck and Norris hospitals, we specifically state in the policy that the medication cannot be ingested on the premises of our hospitals or clinics. I also asked, where do we refer patients who are interested in this law? They should be referred to their primary care doctor, Dr. Puri said. If the primary care physician determines that the patient meets criteria, they need to make 2 oral requests at least 15 days apart directly to their doctor, and it should be recorded in writing. I asked if we had better symptom control and pain management for patients who are dying, would we actually have a need for this law? And Dr. Puri responded that evidence from Oregon and Washington demonstrates that the majority of patients who are in possession of the medication actually are already enrolled in hospice care. This suggests that when optimal symptom management is in place or is being attempted, there is a population of patients who still seek the medication. I also asked what type of feedback has she been receiving from her colleagues, and she said reactions have been mixed. Staff who morally object to being involved are allowed to make that choice. However, there are many colleagues who advocate for this law and are happy to see it put in place. And I also asked, can a patient be receiving hospice care and also receive a prescription for the medication? And she said, yes, absolutely. In fact, as noted above, in Oregon, most patients who have obtained this medication are already enrolled in hospice care. Thanks for listening, and once again, I thank Dr. Puri for giving me time to complete this interview with her, and I hope you enjoyed. Thanks.
Where do nurses fit in? Nurses who care for the diseased and dying are limited by practice guidelines to follow protocols and implement patient directives. Nurses need to be supported and educated regarding the moral, legal, and ethical decisions of their actions. A study showed that factors that affect nurses' view on physician assisted death include age, gender, and specialty in nursing. Arguments for the right to die law. Arguments that favor the right to die law insist on autonomy and control, compassion, peace of mind, and reduce financial burden to the family. Arguments against the right to die law insist that this law violates the Hippocratic Oath, which is an oath to treat the ill. A patient's pain and suffering can be relieved through other options like palliative care. Choosing to take one's life can demean the value of human life, and many religions prohibit taking one's life. This law can also lead to slippery slope, which can lead to abuse of the system and legalized murder. Religion and the right to die. Different religions have different viewpoints on the believer's right to die on their own terms. The decision to stop treatment, knowing that it will lead to one's death and dying at a time of one's choosing, is a difficult decision to make. It is important that patients clearly understand issues regarding their condition and other options that might include palliative care and hospice. It is important that we provide patients access to organizations that address death with dignity, provide counseling and education.
Hello, my name is Ryan Hood, and I am presenting the references. References are Physician-Assisted Suicide in Psychiatry and Loss of Hope, published in 2013, Withdrawal of Non-Futile Life Support After Attempted Suicide, published in 2013, No Last Resort, Pitting the Right to Die Against the Right to Medical Self-Determination, published 2015. California Governor Signs Landmark Right to Die Law, published 2015. And then we have End of Life, California Senate Bill 128, published 2015 to 2016, Part 1.85, Section 443, Division 1, Health and Safety Code, California Statute 2015. Continuing our references, Nurses' Attitudes to Assisted Suicide, Sociodemographic Factors, published 2015, Washington versus Glucksberg, Patient Autonomy versus Cultural Mores in Physician-Assisted Suicide, published 2011, Physician-Assisted Suicide, Death with Dignity, published 2011, Voluntary Stopping of Eating and Drinking, An Ethical Alternative to Physician-Assisted Suicide, published 2015. Nursing Research, Methods and Critical Appraisal for Evidence-Based Practice, published 2014. And Euthanasia and Physician-Assisted Suicide, Knowledge, Attitudes, and Experiences of North and Angulasia, Spain, published 2012.